Hi, this is Nick Morris for Live at Annual, our neurocritical care podcast. We're exploring the latest sessions from the annual neurocritical care meeting. We've just finished the clinical trial session. I'm here with Dr. Stefan Wolf from Charité Hospital in Berlin. He is a neurosurgeon and neurointensivist and the PI on the early drain trial, which he just described for all of us. And Stefan, welcome to the podcast. And please, for the listeners who couldn't make it to the session today, could you give a summary of why you did the trial and what you found?
Yes, hello everybody. This is Stefan from Charité Universitätsmedizin in Berlin speaking. Well, I just presented results of our early drain trial. This was actually stipulated by work from a US physician, Paul Climo, from Salt Lake City, who presented on lumbar drains in subarachnoid hemorrhage patients in 2004 in the Journal of Neurosurgery, and showing that these patients were prone to have a way better outcome looking retrospectively. And so there was lacking evidence for prospective trials, the reason why we conceived the early drain thing. Basically, what we did is taking subarachnoid hemorrhage patients of all severity grades and randomizing after aneurysm treatment, randomizing whether they should receive a lumbar drain for lumbar cerebrospinal fluid drainage of 5 milliliters per hour for the first week or not. The idea would be that the blood gets better out from a lumbar drain than the EVD because, well, blood is, the erythrocytes have some weight. They tend to sediment by weight. They get down in the basal cisterns where the fluid is located in the subarachnoid hemorrhage patients, and the lumbar road seems to be more better to get this out. This was the physiology behind that, and we were able to show that this was to be done safely. We didn't have a high complication rate. It was actually lower than in standard of care, having an EVD as required, or no EVD if not required. And yeah, we were able to show that it was safe, and we succeeded in having a better outcome for the patients measured by the modified ranking score at 6 months. We were also able to show that this early lumbar drainage of cerebrospinal fluid leads to less infarctions, secondary infarctions at discharge, which are mostly triggered by vasospasm. The vasospasm rate itself, however, was not affected by the lumbar drain. And these are basically our findings. You can read this if you want to have in JAMA Neurology, this month's issue, August 23.
Great. Well, I think all of us were very excited when this study was first released online and we got to read it. And at this point, we've already had journal clubs and discussed at length because it's honestly, it's the first major positive trial we've had in subarachnoid hemorrhage management in decades. And
Yes.
It's very, very exciting for all of us. We have employed at University of Maryland, where I'm a physician, lumbar drains for subarachnoid hemorrhage in the last year, actually, even starting before the trial was released. And we learned some lessons along the way, and we learned more lessons from your paper. And one of which was this idea of actually measuring the pressure gradient between an EVD and a lumbar drain. And I mentioned that because we had a pause in our practice after we had a patient herniate due to brain sag. And probably from over drainage from the lumbar drain. And we were not measuring ICPs at that time, and we didn't have a good solution until we read your paper, and we decided to use this protocol. Can you talk about how you came up with this protocol and why it's maybe important for safety?
Well, the safety issue was the main consideration in the beginning. And in fact, some of our centers participating wanted to include only good grade patients being awake, being easy to be monitored, because they thought it would be more safe to use the lumbar drains in these patients. Others of us were more prone to use it in the high-grade WFNS patients because they seem to be benefit more. And this was actually the population which was introduced in this premature trial by Paul Climo. So there was a clinical equipoise which patient to include, and we really did not know. And to overcome the safety issue, we took a proposal from a colleague of ours from Germany, Dimitris Dajkov from Erlangen, who measured actually the pressure gradient on both a lumbar drain and an EVD inserted simultaneously in a patient with subarachnoid hemorrhage. This was done shortly before early drain was about to start. And we decided to include this idea as additional safety measure. And the idea is simple. If both are zeroed on the acoustic external acoustic channel, they should measure the same pressure level if the CSF pathways are patent. If there's a difference like clotting and blockage in the, let's say, aqueduct or even the ventricular blood, there should be a difference in pressure with the lumbar drain being lower reading than the EVD. And this gradient gives you additional safety. This was nicely shown in this paper by Dimitri Spikov, references in the final early drain paper as well as in the protocol. And this really gave us confidence to do this safely. Having said that, I remember the numbers from actual early drain, lumbar drain, the difference between both pressures was 1 in 144 patients randomized to lumbar drain. So the occurrence rate is low of this brain sagging. I don't know the particular features of your case. This may be interesting to learn. It sounds a little bit unusual because I usually do not get this in awake patients. This is only the utmost severe patients. And then I question whether that would be really the lumbar drain or just initial hemorrhage severity. And the patients would be too worse anyways, but need to learn more about your case.
Sure. And so since we changed our protocol, one thing we've noticed in the lower grade patients is we are big believers in trying to let them have some sleep during their ICU stay, especially if they otherwise are doing well. But when we're measuring this pressure gradient every hour, of course, it becomes harder and harder to get sleep in the ICU. And so I'm wondering maybe if, as you see looking forward, if the pressure gradient should be measured in high grade patients, but perhaps we may not need to in low grade patients. What are your thoughts on that?
Well, this was not specified in the protocol. It was up to the discretion of each local investigator. And I can only tell you my experience from running this trial and continued use of lumbar drains. It seems to be that the good grade patients do not need both an EVD and a lumbar drain because you can perfectly monitor them on a clinical basis. I would, however, recommend to do this in high grade patients, being on the ventilator or using more invasive monitoring like oxygen probes or something like that. If you think you need that, you probably want to have both an EVD and a lumbar drain for safety. And it seems to be rare, but still, if you catch that issue upfront, it may be better. And second thing is, to my current understanding, lumbar overdrainage from brain sagging is completely different from classic herniation by pressure forcing in the brain down in the cisterna magna, and there's a completely difference. The one has high ICP and the other has low ICP. So this may be interesting to know the features of your patient.
Yeah, it was quite interesting that the ICPs were not high at all. They're actually quite low. And to treat the patient, we actually instilled sterile saline into the lumbar drain with immediate improvement.
Yes, we do that in case of accidental drainage, over drainage. We do that as well, and seems to work safely and feasible. I've never seen any problem with that.
One thing I noted in the paper was, as you said, the EVD management was up to the institution.
Yes.
Do you have a sense of what the common practices were for EVD management with lumbar drains? Were most institutions keeping it open, keeping it closed?
No, we did not, unfortunately, record this data in our case report form. This is one of the few of the lots of shortcomings. If I'm looking more detailed, I find more shortcomings over the way, but this is with every trial you do, probably. I would assume that I visited each center in person to ensure compliance to the protocol, and issued the safety issue with both gradient measurement in each center. So at least in the high-grade patients, pressure was regularly monitored. In Berlin, we stick with this work just to keep the EVD closed and open it up on demand. This is backed up by I think work from Duke University, Darby Olsen did that, showing that closed EVDs have less infections, less clottage, and less prone to complications like dislocation and any other problems. And it seems to be natural. Having looked at the statistics, I think 70% of centers do have an open EVD protocol, and only 30% have this closed and open on demand protocol. I've said that on the podium before. We are doing additional analysis now to see whether the drainage rates of EVDs correlate to outcome. And it seems to be that draining the blood out of the basal cisterns via EVD is not a fortunate idea. But this is preliminary. This is not in the paper for good reason, because we did not randomize for that and did not investigate that. Otherwise, it would be completely difficult to understand.
Interesting. And you mentioned this outcome of looking at secondary infarct, and some of us have noted that in the control group, the rate of secondary infarct, which was mostly by CT scan, if I'm correct, was quite high. It was nearly 40%. And in some of our own institutional data we looked at, our rates seem to be much lower. And so I'm wondering what your thoughts are on this rate and how, if you looked into that.
This is one indicator for quality of care, and you may argue that this rate is too high. However, keep in mind that most of our subarachnoid hemorrhage knowledge comes from previous trials, like the clazosentan trials, CONSCIOUS 1, CONSCIOUS 2, or the nimodipine Newton Edge trial. And these were trials having an enriched population, prohibiting the most severe patients entering the trial. So this is usually WFNS grade 1, 2, 3, and 4, maybe not even grade 1. So this is patients having a lower infarction rate. And in early drain, about half of the infarct rate was in the high-grade WFNS 5 patients. This is data presented more on the supplement side. I think it's supplement 2, but I don't know the correct figure number. Have a look at that. These high-grade patients contributed to about half of the infarction rate. So it may depend on your local policy, which patient to treat, which patient to include in for the lumbar drain, and which patients you're looking at. And this is just a perception bias, to my understanding. And this is also backed up by one paper from Alejandro Ravenstein from Mayo Clinic, who is one doubt probably one of the best clinics in the world to treat subarachnoid hemorrhage. If I want to have a subarachnoid hemorrhage, probably want to have it there for the expertise. And they did have an extraction rate for 39%. The paper of 2004, 2005 in stroke, which was reassuring to me. We are just on par with this level, having a mixed subarachnoid hemorrhage grade population.
Okay. And then lastly, any thoughts about why the secondary infarction rate was so different with no change in vasospasm?
Yeah, this is the key question, and I have no good answer on that, because this trial was designed to show the evidence that it may be appropriate and advantages to use a lumbar drain. It was not for physiology studies. There's some work coming out of Boston ICU on splenic depolarizations, which is a precursor of infarctions. And these splenic depolarizations may be triggered by ICP spikes, which are higher in the control group. And they may also be triggered by a higher ICP level, which was also higher in the control group in early drain. So I could only speculate on this, that the lumbar drain seems to be promoting the natural CSF flow better than an EVD, just to prohibit stasis of the blood in the basal cisterns. So, and if you have more regular CSF circulation, this always happens, regardless how much you are training, this may be better for the patient.
Okay. Well, let that be the last word. Thank you so much, Dr. Wolf. Congratulations on the early drain trial. This has been really a game changer in neurocritical care, and we're all very excited by it. And we look forward to more research from you and your group.
Thank you very much.